So yeah, we'll go ahead and we'll jump in. Okay, so I'm gonna give us a quick overview as we're kind of going through here. So those first things I'm gonna go through kind of quickly, like the what it is, because I'm assuming you guys kind of know what selective mutism is, so we'll just kind of refresh our memories on that. I'll talk a little bit about assessment, some particular measures that really tap into it, and then a little bit of like an introduction to the treatment, and then we'll talk more in depth about what PCIT-SM is. And somewhere in here too, I am going to kind of talk about PCIT a little bit, just for those of you that are familiar with it and how it might be different for adapted for selective mutism. Okay. Like I said, I'm going to go pretty quickly through here because I'm assuming a lot of us know what selective mutism is. I just find it interesting to kind of keep in mind like the history of selective mutism as a diagnosis, just because it kind of frames things a little bit in terms of it's a relatively newer diagnosis compared to some other ones. And originally when it was recognized as a diagnosis in the DSM, it was the DSM-3, and it was called elective mutism. And it was under disorders of infancy, childhood, or adolescence. In the DSM-5, or 4, I should say, it was changed to selective mutism. And then still in the disorders of infancy, childhood, adolescence. And then in the DSM-5, it was actually reclassified as an anxiety disorder. So I just find it kind of interesting to acknowledge that this elective mutism, it was kind of originally thought that people that were not speaking in some settings where speaking is expected, but speaking in other settings, that it was elective, it was more of a choice. And I think that's something that can sometimes be a misconception with selective mutism, because it's not a choice, it's an anxiety disorder. And when we kind of think about that and we talk to parents, teachers, etc., and kind of be like, yes, this is an anxiety disorder, that kind of helps people to frame it in a helpful way. The prevalence of the prevalence of SM, selective mutism, is pretty low. And the mean age of onset is kind of like the preschool, kindergarten years, because if we think about it, prior to that, kids are mostly interacting with people that they know really well, their parents, extended family. It's a lot of times, even like just anecdotally, from clients I've worked with, that we see it kind of showing up really as a problem once a kid enters some sort of school setting, be it daycare, be it preschool, kindergarten. But there is often just acknowledging this time lag sometimes between when the onset and when it actually people come in for treatment. High comorbidity with other disorders as well. I'm again assuming you guys know this, so just keep in mind selective mutism, speak in some settings, don't speak in others. Typically school. That's why it shows up once kids enter a school age. Is typically that's a common, like, we don't speak at school, or our speaking is different at school. From an assessment standpoint, so the good news here is that the way like I was trained to do the assessment part of assessing for selective mutism fits very, very nicely with the way that we do intakes at light and anxiety. Because with a kiddo with selective mutism, we want that first intake to not have the kid, because we want to be able to talk to parents and get the information we need from them to kind of help us figure out how that first session with the kid is going to be. So I was kind of trained as we have like we have the intake that's parent only, and then that first session with kid is more of an observation. I'll kind of talk about exactly what it looks like a little later on. So just some tips of things to keep in mind when you're assessing for selective mutism, some questions to ask parents. We want to think about their verbal, so specifically verbal. You got to sometimes be specific about that, because parents, teachers especially, will say like, oh yeah, they participate, and they sometimes mean they participate by like they're doing the motions for the song, but they're not singing. So we want to be specific that we're asking for a verbal. Or they'll be like, yeah, they respond because they nod their head and they shake their head. And it's like, no, we're looking for the specific verbal. So we want to know about their verbal behavior in these different settings, at home, at school, in the community. So if they're in extracurriculars or even like birthday parties, extended family, we want to know where the failure to speak is happening. And we also want to know with whom. So is it with family, extended family? Is it with, how are we with friends? How are we with teachers, classmates? These different levels of familiarity. And then how is the kid with someone totally unfamiliar? And I have some questions up here for you guys just to kind of some ways to assess for this. Like, how would your child react if they're at a playground, you know, a park, and another kid around their age comes up and starts talking to them or asks them to play? Like, what would they do? And that gives you a lot of information. If a parent says, oh, they would freeze, they would run away, they would look at me, versus a kid with selective mutism would do more of like, they would just kind of join in. And also I typically ask, like, how would your child react if an unfamiliar adult, I usually give a specific situation, asked how old they were. So maybe like you're at a grocery store and the clerk that's like helping you guys check out your items, you know, makes a comment of like, oh, you're so cute. How old are you? What would your child do? Would they answer? Would they hold up fingers? Would they look at you like at the parent all panicked? Would they kind of hide behind you? Those are the things that we're kind of looking for. And also during this first intake, I always explain what selective mutism is, that it is an anxiety disorder, how we go about treating it, particularly since I use this PCIT adaptation. I kind of explain what that's going to look like, because we really want parents to understand what we're doing and why we're doing it with this intervention, because otherwise it can be really confusing, for lack of a better word. And I'll talk about the pride skills later as well. So second intake, just a few things to keep in mind. We don't want to initially address the child. What I mean by that is we don't want to set up the expectation to speak. So we don't want to say, hi, so-and-so, it's so nice to meet you, or my name's this, what's your name? We don't want to do those types of things because we need a warm-up period. That's the problem. It's like we need a warm-up period. So I usually just say something like, oh, so-and-so, you're here. It's so great to see you. You and mom can come back with me. We're going to be in this room today. So it's not that you're like ignoring the child. You just got to be careful with the way that you're greeting. I usually try to, if there's time in that first intake, to clue parents in that why I'm doing that, because a lot of times parents will prompt. And then if they do prompt, sometimes I'll say something like, oh, no, we're not going to ask that right now. Those types of questions can be kind of challenging. Same kind of thing with the saying goodbye. So I try to avoid that. I just say like, okay, see you later. And if parent tries to prompt, I try to kind of make sure we don't have a failure to speak, but kind of have to work with parents in the moment. So during this first time the child's there, the second intake, you want to make sure, particularly, a lot of this is going to depend, I should say, caveat, on the level of mutism, the severity. So some kids will like be totally cool, like talking to their parent in front of you. They might even like say something to you, but they could still have selective mutism. And then we got some kids that are not going to say a word. So like the first goal that we're working towards is them speaking to their parent in the office without you in the room as a therapist. So the way that we do that, traditional PCIT will do like the one-way mirror idea with like the bug in ear, you know, so that you can tell parents like, okay, now say this, do this. You're like doing that live coaching. The way that I typically do that for selective mutism is depending on the severity. So depending on the severity, I might be able to just kind of like hang out in the hallway and kind of with the door open a little bit and hear if kid is speaking in that respect. And then I'll like jump in with like a post-it note of like cueing parents, particularly if I'm working with a young kid that can't even read. That works really well. If we're a little more on the more severe, if you will, side of things, I will set up my phone in the room and using a Google Meet link, be able to view what's happening live when I'm not in the room. And then I would still do either a like post-it note type thing if I'm wanting to like cue parents to do something, or another way to do that would be that we could set up that bug in ear kind of idea. I have on here, like, after about 10 minutes go into the room. That really depends. Some kids will, as soon as you leave the room, some kids with selective mutism that weren't speaking before are off speaking to parent. So you can kind of push that a little bit. It doesn't really have to be 10 minutes. But you go into the room using defocused attention. So I usually say something like, oh, don't worry about me. I'm just going to check this thing over here. Sometimes I'm more specific than that, but it doesn't really matter. You're just kind of trying to communicate, like, I'm not paying attention. I'll even sometimes turn my back. And what I'm listening for, if I'm listening, how have the kids' verbalizations changed since I entered the room? And then it's easier to cue parents to provide that live coaching when you're in the room. So then you can kind of be doing that. Depending on the kids, again, level of mutism at this point, you might need to, like, leave the room because they completely stopped responding. I might need to step out, step back in. And then depending on their verbalizations, I would start kind of using the CDI. We'll talk about what that is, the pride skills, and cue parents accordingly. And if possible, and I do sometimes have this happen, we can fade parents out by the end of the session to really test that limit of how does the kid do with just me in the room. Like, I'm a relatively new person. Are they speaking to me? And the things we want to keep track of are when they speak is if it's prompted or spontaneous. So prompted meaning like they answered a question, a direct command to speak, versus spontaneous. They just, like, look at me and they say, my favorite color is purple. And I'm like, oh, thank you for telling me that your favorite color is purple. Something like that. Briefly, some measures. I'm not going to go super in depth here. I just want you guys to be aware that there are some measures that specifically assess for selective mutism that I do use with my clients with selective mutism, in addition to a more broad anxiety measure as well. So the selective mutism questionnaire is for parents, and it asks about a child's verbal behavior in different settings, school, family, social situations outside, so like community, and then how distressing they find the symptoms. There are norms for this that can be found in that article that I have there. The reason I mentioned that is because compared to the school speech questionnaire, there are no norms. So this is more like comparing, like, every treatment plan update, how are we doing kind of thing. So the school speech questionnaire is much shorter, and it is questions that the teacher answers, which can be helpful. It's also helpful to set up a consultation call with the teacher so that you can provide some psycho ed about what selective mutism is, how it's reinforced, and I recommend kind of doing it at the beginning. And a lot of times, just to kind of make it all in one piece, I'll have that first consultation call and I'll ask, like, tell me about, like, what you're seeing. You know, I'm asking some of those similar questions to what I ask parents during the first intake. And then I'll also even just be like, hey, can I ask you some structured questions off of a rating scale? And they're usually like, sure. And I just go through it real quick, you know, only takes a few minutes of the teacher's time. And then that gives me another data point in addition to what they tell me. I'm not going to talk too much about these, but just for those folks that are familiar with PCIT, there is a kind of similar coding system. If you have no idea what I'm talking about, that's totally fine. If you're like, I don't even know what PCIT is, I'm still confused, just ignore me on the slide. But basically, there's ways to code, there's certain thresholds in PCIT of where parents have to meet in order to, like, kind of move to the next phase of treatment and things like that. I just wanted you all to know that there is a similar thing with PCIT-SM. Caveat, I don't use it, but it does exist. Okay, now to the good stuff, the reason we're here, the actual treatment of selective mutism. Treatment rationale here, as you guys know, selective mutism is an anxiety disorder. So that means that children with SM do show that fight, flight, or freeze response. Typically, it's more of the freeze. I have had kids that do try to do more of, like, the running away, more of the flight. But we can think, again, it's anxiety, and we will treat it as such. So we can kind of think about that selective mutism is maintained by avoidance, like many anxiety disorders, and treated by approach. What does that mean? A lot of times I will actually talk to parents, schools about this cycle so that I can kind of explain how the selective mutism is being reinforced, because that's one of the issues with selective mutism, is that it is constantly being reinforced. So I'll kind of go through this, just kind of explain like where we target treatment. So first thing that we have is the child is prompted to speak. So with a parent, this could be something like, even like just in a session, it could be, tell Dr. Anna your name. That's a prompt to speak. In a school setting, it could be something like, if they have like their free play or choice time, what are you going to play with? Any sort of question or direct command to speak. That child becomes anxious. What do we do when we're anxious? We avoid. And then a lot of times what happens is not only does the child become anxious, but the adults in the situation sense that discomfort and come in and rescue. And that's very understandable. And I always try to normalize that for teachers, normalize that for parents. It's like, you're seeing that this child is distressed. You're seeing that your child is distressed. Of course, you're going to jump in. But the problem with that is that makes everyone feel better. And that reinforces the selective mutism. So what we want to focus on is this part, the child avoiding and the adult rescuing. And the way that we do that is we turn this into approach. So what we do is we practice a small goal with a child, which could be something, could be a lot of different things. A common one that we'll do, particularly in those intensive groups, is like ordering ice cream. So it's like, we'll practice ordering ice cream. So I'll say, okay, we're going to practice. Pretend I'm the person behind the counter. What kind of ice cream do you want? And then they tell me chocolate. And then I'll talk about rewards in a second. I'm like, that was great. You want chocolate? Here's a sticker. And we keep practicing. I already talked about that external reward. That is a sticker, particularly for young kiddos. Older kiddos, you can see if they want stickers or do more tallies or something like that. Then we might go on to the real situation. So we might say, okay, we're ready to actually try that at an ice cream shop. Same kind of thing could work for, like a coffee shop as well. Or we do the next small goal. So maybe we're not quite ready because all we said was chocolate, but we weren't ready to say what size we want. Or do we want a cone or a cup or something like that? So then we might have to practice that and kind of add that on. We have reinforcement from the adult in the situation. And our anxiety, the kid's anxiety in this case might decrease, but this is an exposure, right? Think about this as an exposure. The anxiety might come down, but it might not. But regardless, we are reinforcing the speaking, which is what we want to do. Okay, a little bit just about like the progression of treatment goals, or the hierarchy, if you want to think about it that way. So our first goal is always for kids to be verbal with parent or parents in the office. That happens sometimes immediately in first session. Sometimes it happens by the end of first session. Sometimes it takes a few sessions. It really just depends. I've seen lots of variability in this. The second step is we want to transfer that verbal relationship to the clinician. So basically, you can think about the verbal relationship that the kid has with their parent in the office. We then want to transfer that to me as the therapist so that the kid is directly verbal with me. Once that happens, that opens up all kinds of doors for generalization. So then we can generalize in other settings. That's when we can do like some stuff at school, in the community. So what I was saying about like going to an ice cream shop, going to a coffee shop, those types of things to practice. And we can start to generalize to people. So we can transfer that verbal relationship to teachers or to certain teachers if a kid's only speaking with one teacher, to classmates, to people in the community, wherever it might show up. And the three types of verbalizations that we want to keep in mind as we're working on the speaking with a kid with selective mutism is we want to work on responding, initiating, and engaging in spontaneous speech. So I said earlier, responding would be like answering a question or a direct command to speak. Initiating would be like asking me a question. Spontaneous and initiating are like, it's not too important that we differentiate there. That spontaneous would be more just kind of like a small child just randomly declaring something rather than like asking like a question or something. Typically, responding is easier. Initiating and spontaneous are harder. I do want to just, for your guys' knowledge, comment on this idea of contamination in the context of SM. So contamination is basically, as I talked about, this mutism is constantly being reinforced. So even if you're working on it in session, it's probably still being reinforced at school. Even if parents are doing better at home, it might still be being reinforced elsewhere. So really what the contamination is referring to here is where the repeated exposure, so like at school, for instance, to accommodating a nonverbal response or avoidance of a verbal response, or a lot of times we say a failure to speak. So that is being reinforced. And then sometimes we can say like that situation has been what we call contaminated, meaning that they associate essentially, I don't speak at school. I've actually had little kids tell me that. I don't speak at school. I don't sing at school. I only sing at home. Kids with SM can have these really rigid rules. That doesn't mean we can't still move past them, but it's just something that's important to keep in mind. All right, now to the good stuff. PCIT-SM. Okay, I'm going to talk a little bit about how PCIT-SM is an adaptation of PCIT. That's going to be super helpful for those of you that are familiar with PCIT. If you're not familiar with PCIT, just focus on the column that's PCIT-SM. So PCIT is parent-child interaction therapy. And it's usually for kids that are having more externalizing presentations, so like tantrums, things like that. So it does work a lot with parents as being like the agent of change, as we have here in this table. It does have that very structured coding system and the mastery criteria to move on to the next step, which that's why I kind of acknowledged to you all that that does exist in PCIT-SM as well. There is the reinforcement in PCIT-SM. We use stickers typically. There's coding of the parent-child interactions to inform the coaching. So there's parent coaching happening in either one. Of course, the measures are different. What I really want to highlight is actually this slide. So apologies that this is a lot of information on one slide. So in PCIT, we have CDI, which is child-directed interaction, and we have PDI, which is parent-directed interaction. In PCIT-SM, we still have CDI, which is the pride skills that are listed there, and we'll also talk about those in a second. And then instead of parent-directed interaction, we have verbal directed interaction. So if we can think about this as in traditional PCIT, the goal is compliance. We are trying to get the child to be compliant with the parent's directions. In PCIT-SM, the goal is the child speaking. The behavior target is the child speaking. That is what we are focusing on. So that's why our second components are a little different. PCIT-SM, the focus is on the speaking. The do's and don'ts. So with PCIT-SM, we can use question end arounds, which is basically a way of like not asking something as a question if we think the kid's not ready to ask it as a question, but it's something we still have to ask. An example of this could be if a teacher needs to ask a kid if they need to go to the bathroom, but the teacher already knows that the kid historically does not answer them, will not answer that question, but we kind of need to know. So then we could just say something like, go to the bathroom if you need to, because then we're avoiding the question, we're avoiding the direct expectation to speak. We also really play to child's strengths. That's important, their interests within PCIT-SM. Of course, in the don'ts, when we're in CDI, we're doing child-directed interaction. We are following the child's lead. We are using those pride skills. We are warming the kid up, if you will, particularly in PCIT-SM. We want to avoid the questions, direct commands, criticisms. We're really just like following the kid's lead when we're in CDI. Another thing to keep in mind is we want to avoid mind reading. So if a kid points to something, we don't want to say something like, oh, you want that one. Because then we're assuming, and we want them to be able to verbalize. In PCIT-SM, we do involve other people. I talked about like teachers, other therapists sometimes. Other therapists at LOA have gotten roped into being involved with some of my clients. We do have exposures in the token economy, the stickers in PCIT-SM. I will talk a bit about the groups, intensive groups, in a moment. And then let's see, there is a lot of modeling that happens in PCIT-SM on the part of the therapist for the parents. So in a traditional PCIT, the therapist is on the other side of the one-way mirror and has the bug in the ear for the parent and is telling them what to do. We have a little bit of that in PCIT-SM, but we also do a lot of that in the moment in the room. And that is really helpful because then parents are like seeing what it looks like from the therapist doing it as well. All right, I've already kind of talked about this, but there's kind of like these two phases. There's the CDI, the child-directed interactions, which are the pride skills and not asking questions. And then there's VDI, which is the verbal-directed interactions. And then once a kid is verbal with someone, then we can transfer that verbal relationship. So CDI, like I said, I'm following the child's lead. We're using the pride skills, lots of reinforcement, lots of stickers. We already talked about the don'ts. So the pride skills, I want to say, if I'm remembering correctly, and I think I am, that these are the same for traditional PCIT and PCIT-SM. So P stands for labeled praise. So this is being specific about what we like that the child is doing. So if the child is putting something, like they're building something, we can say, oh, I like how you put that block there, or something like that. If they're saying something, we can say, thank you so much for telling me. I say that all the time. Thanks for telling me. Thanks for letting me know. Reflection is repeating what they're saying. So if they say, like in the example here, I have a purple balloon, we'd say, you have a purple balloon. I would actually disagree with the, oh, a purple balloon part, because we want to be a little more verbatim when working with kids with SM. Imitation could be something like, oh, you're drawing with a red marker. I'm going to draw with a red marker too. So like we're still talking in CDI. It's just that we're not asking questions or putting that expectation on the child that they need to speak. But we as the therapist are still saying lots of things. Behavioral description, I kind of use that with like the blocks of like, oh, you're putting that block on top of the tower. And then we want lots of enthusiasm. We want to make it fun. We want to make it enjoyable. That helps. All of the pride skills help to just kind of reduce that expectation of really putting like the focus on like you're speaking, you need to speak, and just kind of makes it like, oh, we're just playing and I'm just talking, and it's a lot easier then for kids. I do have an example here, and hopefully we can get it to play. Give me one moment. I'll switch to there we go.
Looking at the Lego pieces. You picked up a black Lego piece and put it on top of the tower. You're saying You grabbed a gray piece and you put it on the black piece. Great job. Yeah, putting the gray piece on the black piece. And you put a hanging Lego piece on the gray piece. I really like the structure that you're building. You're grabbing a gray piece. Great building. My building's gonna have a diving board. Great job putting a window on your building. I really like all the different types of Lego pieces that you're using. You're nodding your head.
Okay, you guys get the idea. I just wanted you to kind of see a little bit about like what this might look like. The only thing I would maybe add in here would be some like reinforcement with stickers, particularly if it's a kid that I should have mentioned earlier. Kids with selective mutism sometimes also have behavioral inhibition. So for some kids, part of what we're also working on is like even just playing in a room. I've literally had kids that were like frozen like statues, and that was something that we also had to work on. Okay, we don't need to watch it again. Oh yeah. Okay, so VDI, this is the exposure. So this is, we're still using the pride skills, those never go away. We're still using the rewards and reinforcing, and we're asking valid questions. I'll talk about that in a minute. So we don't want to still, same things, criticize, mind read, rescue, or enable. So we'll talk about what specifically to do if a kid doesn't give you a verbal response to a question, for instance. So valid questions are forced choice. So do you want the red or blue marker? Open-ended, what color marker do you want? Direct command to verbalize, tell me which marker you want. Invalid question would be a yes or no. Problem with this with a kid with SM is it elicits a nonverbal. So we're really working on that verbal. So if we say, do you want the green marker? And they nod their head, that's not what we're going for. Our target here is verbal. Eventually, further in treatment, you can ask yes or no questions, and kids will give you a verbal answer. Or you can prompt them of like, oh, tell me with your brave voice, or tell me with your words, or tell me yes or no. So there are ways like later in treatment, but early in treatment, I'd say like avoid those yes nos. All right, here's an example of what VDI looks like.
So Sarah, do you want to use the markers or the crayons next to draw? The markers. Thank you for telling me the markers in a nice full voice. I'm going to give you a big check for that. Sarah, do you want the cookie or candy? Cookie or candy? Do you want the cookie, yes or no? I see you nodding. Is that a yes or a no?
Yes.
Yes. Thank you for telling me what you want. I'm going to give you a check for that. Sarah, would you like to use the markers or the crayons to draw? I see you pointing. Would you like to use the markers or the crayons?
I want the markers.
You want the markers. Thank you for telling me in a nice full sentence. I'm going to give you a check for that.
See.
Sarah, do you want to watch Cinderella or The Wizard of Oz? I see you moving your mouth. Please say it a little louder.
Cinderella.
You want to watch Cinderella. Thank you for getting louder. Okay.
Sarah, what do you want for a snack today? Do you want Cheetos or chips? Or something else?
Something else.
Something else. Great telling me you want something else. Do you want Goldfish or Fritos?
Goldfish.
Goldfish. Great choosing. Thank you for telling me.
Okay. So we saw there that they were using check marks instead of stickers. We saw a lot of the those things I've been talking about. And in that last example, they were starting to kind of show what to do if a child doesn't respond. And there was also some examples there of what to do if a child gives a nonverbal, right? We can describe the gesture. We'll talk about that in just a moment. Yeah, let's Let's talk about that actually.
So Sarah, do you want to use the markers or the
All right. Okay. So in this flow chart here, this kind of helps us to know what do we do when we get different types of responses. So if we have a valid question, remember valid is not a yes or no. Valid is either a forced choice or an open-ended. I'm going to give an example of an open-ended question as we go through this. So I'm going to use the example of what they said in the video there of what snack do you want or what do you want for snack. So if my valid question is what do you want for snack, I might get a pretty quick verbal response of whatever they want. So like, let's say in that example, they had chips. So let's say it was chips. And I'll say chips. Thank you so much for telling me. And I put a sticker on their sticker sheet. I just use like a blank piece of paper as my sticker sheet. I might get no response. And you saw this in the video. We wait 5 seconds. There was kind of a timer going at the bottom. And then we either repeat the question or reformat. So reformat meaning we might go from an open-ended to a forced choice, which we saw in the video. If we get a nonverbal response, so that means we point, like, let's say, like with the cookie and the candy or whatever, she points, right? Then we could say, and you heard this in the video, we can say, you're pointing. And I found it helpful to not just say you're pointing. Eventually kids kind of figure out that they're supposed to say a verbal response, but to say like, you're pointing, tell me with your brave voice. You're pointing, tell me with your words. Something like that. Or I think we might have heard like loud voice or full voice. I've heard that as well, particularly for kids that sometimes some kids with SM like whisper. And then it's the same thing. We describe the gesture, prompt again, and then we either get that verbal response and we follow that, or we get a nonverbal response and then we want to wait 5 seconds and plan B. I'll talk about what that means. So plan B could be a few different things. It could mean if we're in like a group of kids, it could mean pulling the child with selective mutism to the side and asking them again. It could mean trying the question later. It could mean if we have a verbal intermediary. So for instance, during a session, especially early on, if a kid's not yet consistently verbal with me and I ask them a question like, are you going to color or do you want to play with the cars? And I get a nonverbal response and I try again, forced choice question. Wait that 5 seconds, still get a nonverbal response. I would say something like, tell parent if what you want to play with. And then I might also need to like step out of the room sometimes if it's like still too hard in my presence, or sometimes parents, to parents, kids will like whisper or something like that. And we would still reinforce that and say like, oh, thanks. Like if I can hear it, if the kid says like markers and I hear them tell parent, I'll say markers. Thank you so much for letting us know. Give that sticker on the sticker sheet. If I can't hear because it was more of a whisper, I'll then ask parent to tell me, and parent will tell me, and I'll still say markers. Thank you so much for letting us know, and give that sticker. This is just kind of like a general what we can expect the treatment progression to look like. Keep in mind that there is a lot of variability here. So this is just kind of a ballpark. If you have a kid with SM that you're working with that doesn't fall into this nice, neat by a number session, that's totally fine. So we can think about the session 1 as being the second intake for us at LOA, with the first session for the kid. So by the end of like our first couple sessions, or even just like the first thing we're kind of looking for, is for the kid to not be scared, avoidant when starting a session. Particularly with young kids, that happens pretty fast. They warm up and they're like, oh, okay, yeah, you're Dr. Anna. I know you. I know what we're going to do. Like, cool. Few more sessions, the things we're looking for is talking to parents and the therapist, both in the room. So like I said before, we want that verbal relationship with the parent to be in the office, and then we want that to be in front of the therapist, still talking to parent, and then we want directly talking to therapist. After that, we want directly talking to therapist without parent. So that's kind of what we're seeing here in this progression, is like talking to parents and therapists when both are in the room, then talking to therapists without parents in the room. I will just kind of note that it's doesn't necessarily take 6 sessions. It can, but I've also had, we get to that point where a kid is talking to me without parent in the room in our first session with the kid. So there's a lot of variability here. I also have had where it does take like more like 6 sessions for that to happen. Then beyond that, we want to be talking to another adult. So this could be like another therapist, for instance. We might also then start doing school sessions. At the very least, we want to be collaborating with the school from like the beginning of this process, because the mutism is being reinforced at school. So I've done a lot of pushing into schools, modeling for teachers, how to do the intervention, giving them feedback, also just working directly with a kid, wherever at school it's really showing up. So that might be, for some kids, that might be circle time. For some kids, it might be recess or lunch, more of an unstructured kind of time. Just depends on the kid. And then basically, these are the generalizations in our like last couple steps. Reminding you guys of this that we just talked about, right? First step, verbal with parents in the clinic, then transfer that to the clinician, and then we can do all the generalizing. So just want to give you a little bit about what this session progression looks like. I've already talked about the first session with the child, so this is our second intake, that our goal here is for the child to be verbal with parents in the clinic. I've talked about all of this. It might happen in the first session, that second intake, it might not. But that's what we're looking for. And we already talked about that, so I'm gonna move on. Then we want to transfer that verbal relationship to the therapist. I've kind of given you some ideas already of how to do this, but I just have it kind of again, just for completion's sake here. And then we want to do the generalizing. So we do at this point want to kind of work on transferring that verbal relationship. The way I kind of explain it to parents is, once your kid is verbal with me, that opens up so many more doors, because then we can work on transferring that verbal relationship from me to teacher, to coach, to extended family, to person behind the counter at the bakery. Like, we can extend that, generalize that verbal relationship all sorts of places. And I also do a lot of parent coaching to help parents to do that as well. All right. I do have an example of what this transfer looks like. I'm going to see. I'm actually going to skip it just in the interest of time. Basically, it's going to kind of go through, like, in this case, it's 2 therapists. So we have like therapist 1 and therapist 2. So therapist 1 is like talking with the kid. The kid's totally verbal with them. And what therapist 2 does is they do that defocused attention. Actually, they don't do a great job of it in the video, but they should be doing that. They do the defocused attention. And then as the therapist 1 is asking questions, they're in VDI, the therapist 2 starts to jump in with some CDI. And then the way we make that transfer is, eventually when therapist 1 asks a question, therapist 2 jumps in with the CDI of the labeled praise and the sticker. So we're kind of like transferring that. I've heard it say it's like you're transferring the baton, you're passing the baton. We're passing that verbal baton, and then therapist 1 kind of slips back into CDI while therapist 2 goes into VDI and takes over asking the questions and you're doing all the pride skills and all of that. Then eventually we physically fade out therapist 1. That's the general idea. Of course, there's a lot of variability in terms of how long that takes and how we're able to like make that happen. Just want to make sure that I didn't skip anything. Okay. There might be other treatment goals once the kid is verbal with the therapist. So we might need to work on, I mentioned, like increasing volume. Some kids whisper. So we might need to talk about full voice, loud voice, brave voice. In addition to whispering, there's also just low volume. There's a distinction there. So a whisper would be whispering versus a low volume would be, I'm still talking, but I'm just talking really quietly. We could see both with kids with SM. We also want to work on shaping those nonverbals into verbals. And we might, once the mutism has been kind of worked on, there might be other things that are also kind of showing up. Separation anxiety, social anxiety, something else, some other anxieties, because we know it is very, selective mutism is very comorbid. There might actually be some speech issues. I've had that with little kids as well, that once we work on the selective mutism and kind of make a lot of progress with that, I actually sometimes refer kids then to speech therapists because they have some speech and articulation challenges. We might also have dysregulation concerns. So some kids that are so inhibited with the selective mutism, once we kind of work on that enough and they kind of open up, we then like kind of go the other side and we are now too open, too dysregulated. It's like we kind of flip-flopped. We are like too externalizing now. So then sometimes we have to kind of work on kind of reining that in a little bit. All right, briefly going to go through this. There's a lot of research supporting PCIT-SM as an intervention. There is intervention or support, I should say, for weekly PCIT, which is more like what we would be doing. You, of course, can look at this on your own time here, because I'm knowing that we're running low on time. I do want to just for like a moment talk about intensive groups. So we have intensive group behavioral treatment, which really is found to be like very, very helpful. It's very well supported as an intervention for selective mutism. I have some references here, and I have like the full references on my references slide. Just kind of cluing you in that there's like a few different articles. In particular, I point you guys to Lorenzo and colleagues 2020, because that explains really what is this protocol for an intensive group behavioral treatment. We can kind of think about it as like a camp, and that's what a lot of places call it actually, is something like a camp. And it's usually like a week long, and it's very structured, and it's set to like kind of mimic school basically, but it's an intensive therapy. So that's kind of what we might do to help kids kind of work on that verbalization, work on those treatment gains in a therapy setting, in a very intensive group setting. And in these groups, they're one-on-one with a counselor, and the counselor's working directly with them. So that kind of is what that is. Resources here. I point you guys to the Selective Mutism Association. They have lots of great stuff. Kurtz Psychology, Dr. Kurtz is the one that actually adopted PCIT for selective mutism. So he has lots of great stuff on his website, additional resources. There's even some like trainings on there, some of which are free. And then of course, you guys can ask me. As I mentioned at the beginning, I'm at our Lakeview and River North offices. I've already run into a lot of you guys at those places. And I also have my drop-in supervision Thursdays at 11 a.m. And with that,